to this afternoon's Health and Adult Care Scrutiny Committee meeting. A few reminders for everybody. Firstly, this meeting is being live streamed, so please use the microphones and have them pointing at you when you speak. We're not expecting a fire alarm. Should the fire alarm sound, please exit the room and follow the fire exit signs to the right and congregate on the Cover lawn. Please ensure that you address everybody by their full title of councillor, no first names please, and a final reminder please to not hold individual discussions whilst others are speaking. Thank you. So if we could go to apologies please, Fred.
Thank you, Chair. We've got apologies from Councillor Davies and we've got Councillor Morgan attending remotely as well. Oh, and Councillor Gents also sent his apologies.
Thank you. If we could go to declarations of interest from the committee, please. Has anybody got any declarations they would like to declare? Councillor Ketchen. Thank you very much. Anybody else? No. No? Okay, thank you. And then I've got the minutes of our committee meeting on the 2nd of December. Does anybody have any comments, or do you authorise me to sign them as a true record? I can't see any objections, so I shall go ahead and sign them. We'll do that later, thank you. So, items requiring urgent attention, there are none. Public participation, none. So now we move on to matters for consideration or review. The first item is hospital discharges. So we've got a report from NHS Devon and a report from our visit to the hospital on the 24th of November. We have online, we have Dr. Peter Collins, Chief Medical Officer, and is Joe Schill here? Joe Schill. So would you like to present your report, please, Dr. Collins?
Thank you, and thank you, colleagues. And as I've written in the chat, apologies for not being able to attend in person and for the whole meeting today, but I've been called to an urgent meeting at 3:30. I'm grateful for the committee's attention to our update around discharge, particularly pertinent at this time of year. I think the two papers together describe our collegiate and collaborative approach to hospital discharge, which we know is a really important and fundamental part of creating a good experience for our population, and particularly in the winter, keeping flow through our hospitals and urgent and emergency departments. As ever, we will hear of the pressures, and I think later on, colleagues from RDUH will describe how the impact of large numbers of patients requiring discharge who are unable to move have caused problems, as they inevitably do at this time of year as we attempt to deal with surge. But I'd also reflect some of the great work that is described and some of the benchmarking that we see in the paper that Joe is going to present. So I will, without further ado, hand over to our experts, and I'm happy to answer any questions that I can later on. Thank you. Thanks, Joe.
Thank you, Joe.
Come at short notice because somebody else was poorly, so if I don't quite answer all of your questions, I'm very happy to take them away. So just to canter through the paper then, so we're introducing the ongoing work around hospital discharge improvement programme, set firmly in the national context of discharge to assess and our partnership approach. And as Peter has already described, it's very heartening to, I've recently come to this job, but to see the very collective working that's going on across our system. We've set out some outcome measures and we've set out some arrangements for our pooled budget and some detail on how we transact that across the pathways. Moving to the more sort of operational detail, we have structures that are positioned within the hospitals that are jointly populated with our colleagues from social care and our colleagues from the NHS trusts within there. I'm from the ICB, obviously, so I'm a commissioner, but over the last couple of months have been very firmly embedded within the discharge processes within North and East, just to try and get a better understanding of what's happening there and to understand some of the themes a bit better of where there may be good outcomes for people or where we might be able to do things better. So across Exeter, Torbay in South Devon and Plymouth in Devon, those services are pretty much similar in terms of their sort of, whilst they might not be integrated, they're certainly either co-located or sharing space where they can talk about patients. So on page 4, please stop me if I'm going too fast, because I'm quite interested to get to the exciting bit at the end where we've got the improvement programme set out. So on page 4, we've got some information there about how our hospitals feature compared to the southwest position, and some outcome measures that Amy kindly helped us with to show that actually the position in Devon, whilst looks sort of reasonably okay in the data, particularly around no criteria to reside at the end of the day, we're absolutely committed to any patient in any bed needing to be in the right place at the right time. So whilst the data might show that within Royal Devon and Exeter, for example, 18.2% of patients with no criteria to reside, and that sort of sits quite favourably on the graph there. Torbay and South Devon very good at the end, and then University Hospitals Plymouth, but actually that's still kind of not enough for us. We want to make improvements there, because we know that every other bed is very, very challenged as well, and there's people waiting to get in, as Peter describes, either through ambulance transfers or on elective waiting lists. Moving through, I'm sure you've all had a chance to read the explanation of pathways 1 to 3. So we describe pathway 0 as people going home with minimal support, which could be somebody just going home after an elective procedure. It could be somebody going back to their care home where they live normally. It could be somebody going home with the original package of care that they already had. Then we've got pathway 1, which is where people are sort of stepping up into a bit more support on going home. So back to their own home with some reablement or some additional therapy to help them recover. Pathway 2 tends to be a bedded placement for rehabilitation or reablement, and some of that is about building confidence. It's about taking time for additional assessments to take place before somebody gets home. And then pathway 3 is where people require 24-hour care and they would be unable to return home. And a lot of people within pathway 3 will have journeyed through pathway 1 and pathway 2 possibly at some point between the previous time. It's rare to jump straight to pathway 3. So the ASCOF measures that Amy kindly helped us with, we popped into a table there, and again it's evidencing that our outcomes for people after, I think it's 90 days, again look quite favourable compared to the southwest and the national position. And then at the bottom of page 5 we get to the interesting part, which is all about the improvement. Anybody got any questions so far? I'm aware I've cantered through that quite quickly. I'll carry on then. So yes, of course, of course. So the improvement work where we've set out from page 5 onwards, I think it follows your visit back in November. And I haven't had a chance to see the paper, but my understanding was that there was some frustration expressed by some of the staff involved in the processes about either being on site, not being on site, being involved in pathway decision making, or being able to contribute to the outcomes for people. So during the months of December and January, we've undertaken a lot of work, mainly focused around what we call the MAID week, or the MAID event, which is the multi-agency discharge event. And that was a contribution from across our system. So we had people from the ICB, myself, I was involved with a couple of others. We had the head of transformation from University Hospitals Plymouth came and spent several days with us. Sarah Mitchell came down, who I understand is working with Luton and your team in terms of the improvement arrangements. We had people dedicating time from the hospital trust, people from community teams, people from all over. We came, we spent a week there, we spent some time in North Devon last week. and basically met loads of people. We met the discharge teams, we met the discharge coordinators, we met the therapy leads, we met some nurses from the wards, met everybody from the start of the pathway right through to the finish of the pathway. And our Newton colleagues were with us all the way as well. And from there, we've come up with 5 themes of areas that we wish to explore further and work on. And within those 5 themes, there's 15 different work streams that we've kind of come up with collectively to say, actually, this is these are the things that we need to work on, but that might not be working quite so well, or we might want to sort of change the direction of how a decision is made. And as part of that, I think my personal reflection on, I'm a nurse by background, but I haven't worked within the hospital for a number of years. My personal reflection was 2 things really. Is one, how as a system, as commissioners and operational services, we have come together at quite a senior level now again to really concentrate on what it is we're hoping to achieve for people, but also at a frontline level, how committed everybody is to working together and getting things right. And it was really heartening actually when it's the middle of winter and everybody's tired and people are cold and there's a lot of patients needing to have a lot of things, but actually how committed all the frontline staff were to getting it right for individuals. There was no kind of fatigue or tiredness or exhaustion shown, only just enthusiasm to take things forward and move together to get the right outcomes for people. So that was really heartening. So where we are as of today is we are sorting out our governance arrangements. So we've got a delivery group that we've identified, which will be the kind of operational people, the commissioning staff and therapy leads and leads from within the trust, who will look at the 15 work streams that we've identified and agree who's the lead, what's the trajectory, when will we get these changes seen, when will we start to measure improvement, who can we involve in those pathways. And then the sort of higher level governance of that, establishing a steering board, a programme board, which Amy will co-chair with Zoe Harris from the Trust, who's one of their group managers, and Chris Morley, who's one of the directors within the ICB. So the governance, we're just sort of finalising the arrangements for that, finalising the terms of reference for the programme board and the delivery group, and really setting out the themes within each work stream that we want to take forwards. So those themes are the bottom of page 5 on your papers, depending on how you've printed it. We've got early identification, which is about starting discharge planning before people are medically optimised. One of the things that we noticed was that sometimes those people were having their pathways identified quite late in the process. Really thinking about who can we bring in to be part of those decisions, to work with the patients. Obviously, they're key to making the decisions on what happens, but bringing in people who might know them already from community teams, social care colleagues, therapy leads, really advocating for what patients might want within that pathway. Discharge pathway decisions number 2, so that's about strengthening multidisciplinary involvement in those decisions and having clear responsibilities. So lots of that is about understanding from individuals what they would like to see happen, how can we manage risks if people might choose to make unwise choices, having confidence that people going back to circumstances in which that they were living beforehand, that, you know, I might think, oh my goodness me, how did you ever manage, but people being very clear, well, I did manage and I want to manage again, so not overriding people's preferences there, and really thinking about who we can bring in to help with the decisions and help with sort of commissionings arrangements to support people to move out of hospital there. The information transfer process, so we did notice some not necessarily concerns, but having a data set that really helps us to inform the decision making around what we need to commission moving forward is really, really important. Sort of like, you know, at what point do we decide that somebody is medically fit to go? At what point do we decide which pathway they're going to be on? And at what point do we then sort of switch that over to that was a successful transaction, and then we can then identify a data set which will help us with our commissioning arrangements moving forward. So we really need to understand, as an example, within pathway 2 being a bedded pathway, there's a kind of view that some people get referred to the bedded pathway when actually they possibly could have go home, haven't quite got the bit at home right. So if we're commissioning around that, we don't want to commission too many beds because that's what the numbers are saying. We need to think about how many people we want to get home and have an ambition towards moving the bedded bit back towards pathway when we're getting people home. And then the intermediate care and the market interface bit is about how we talk to our market, how we can encourage the market, and we have a very broad market here, don't we, with lots of residential and nursing homes, lots of community providers now. So how can we encourage the market to be part of the solution? So we did notice that sometimes the information that a hospital will send out, for example, to a range of care homes to say, oh, we need to find a bed for Mr. Jones. And it sometimes can take quite a long time to get a care home to agree that they can support Mr. Jones, and we need to understand what is it that's taking that amount of time. Are we giving the wrong information? Is there something that community support that the care home might need in order to support somebody who has challenging behaviour, for example?
Thank you very much. If you could kind of come to the end of your report
Yeah,
fairly soon, that'd be amazing. Thank you.
Yeah, so I'm almost there. So the last part being the shared and accurate data. So the shared and accurate data I've kind of rehearsed already a little bit, will be how we inform our decision making around commissioning.
Thank you so much. Thank you. And I'd like to see, would Amy like to comment at this point, or Tandra?
So I mean, Amy has the detail, but just to echo the points that were made by both Peter and Joe about the close collaboration across the system, and the points on page 5 going on to page 6, that describes our strategy. So the work that we were talking about earlier about what we're going to do with partners to help people out of hospital in a more timely way, it's all tied up in that. So we are absolutely on board with this work.
Thank you very much. Amy, thank you so much, and thank you, Joe. And I'd just like to see open for questions from our committee about the discharge. I'd also like to say thank you very much to the discharge team for allowing us to visit them in November. It was very informative. We heard firsthand from a number of DCC officers working in the discharge team. I found it totally enlightening, and I was blown away by their commitment to working really hard and being so caring for the people of Devon. So it was a really, really good visit. I'm really grateful for that. So anyway, over to the committee for questions. Oh, Councillor Rogers.
Thank you, Chair, and thank you for the information. I've got 3 questions. If someone's been discharged to hospice care, is there any issues with that? If someone lives alone, is there a different tack taken so they're not discharged at home late into the evening and make sure they can't get simple things like a cup of tea or coffee? And is there care plans put in place for every discharge?
It's all in relation to the hospice question, or the 3 separate ones?
The first one is specific. If you're being discharged to hospice care, is there any issues with hospice care provision?
At home or to the hospice?
Either or, to be honest.
Not that we picked up through the MAID week. What we have recognised is that a real commitment to, if people need to go home for palliative or end of life care, they need to get there quickly, and we need to make sure the level of support they're receiving is appropriate for them. In terms of how we transact that, there is still ongoing discussion at the moment within both sites. The process will be that those people are following through pathway 1, so the arrangements will be made through the community teams to support people at home. We have been having some conversations, but very high level conversations at the moment, around whether end of life should sit within the current capacity for pathway 1 that we've commissioned, or whether we should be looking now at something more separate for that individual cohort, recognising their special circumstances. But in terms of the commitment and the processes, I would like to think, happy to be challenged, but I would like to think that those people would be seen as a priority and the support would be appropriate. Moving forwards, I'm sure that there is work that we can do to make sure we've got the right capacity commissioned with the right skill set around those carers to provide for those people.
Question number 2 was discharge to someone home alone. Is it what provision is to make sure that there's no risks of them being discharged to home alone situations?
So as it works at the moment, and again, Amy, feel free to jump in, but as it works at the moment, the therapists on the ward would be making an assessment with that person on their choices, their risks, how they would want to be living at home. Some people want to live at home alone. There would be home visits if it was appropriate to check out the environment, talk to family and friends to understand the risks that might not always be shared by the individual when they're in hospital, and then a support plan wrapped around them following a thorough assessment to make sure that those risks are mitigated and that people shouldn't be at risk when they get there, or if there are risks that they're choosing to take and they've got the capacity to make that decision themselves, that they've got all the phone numbers and all the rescue sort of things that they need to hand. If they suddenly find themselves in trouble, they would understand who to ring and when to ring somebody. If you want to add anything.
Yeah, just to say that we do have really close working relationships with local voluntary partners as well. So if it is just a case of somebody needing that kind of well-being check, make sure there's food in date in the freezer and their home is warm, etc., then we'll always be linking in with kind of local voluntary opportunities. And then if somebody needs that step up, a little bit more support, then that's when our intermediate care services chip in. So that might be our reablement team, it might be a community health team, but just making sure that those connections are in place.
My last question, does anyone get discharged without a care plan, or do everyone get discharged with a care plan?
So if people didn't need any support when they were going home, they wouldn't go home with a care plan, but I'm pretty assured that people would have that discussion beforehand. Yeah.
Thank you. Councillor Julian.
Yes, thank you, Chair. That's a good report. I mean, it covers a multitude of things, actually. But what I wanted to bring up, Chair, is that we went to that hospital thing. If you remember, we brought that up. There was a big gap where the social carers, they only went and saw the patient before they went home just once. And we were listening very carefully, and we made recommendations that they did twice. So you first went there, spoke to the patient there, then spoke to whoever the medical person was there, then had another talk about make sure the provisions, because that was the biggest thing, about being discharged too quickly, going home and then coming back again. So they needed to have that, and they also had maintenance people there to make sure that they could clean the house and whatever maintenance they needed to do there. I'm talking about people that could get home, not the ones that can't. So therefore, I think, you know, with that efficiency, we could save money, and also they need to be listened to. The patient is the patient after all said and done, rather than overlook the patient and then just think upon themselves that they should do this, that, and the other. Because you can't beat it, and we're all the same. If you're at home, you know where everything is, and you heal much quicker. And I feel that that's got to be the ones that can make it home. I want to highlight that. Is to get there and listen to the carers, because they're the ones that are doing all this at the hospital and afterwards, and then coming back and then having another assessment to make sure that they can get home. And we'll all save costs. It'll all save costs. So I feel that that's where we should be going, not rushing anybody, make sure they get it, because as you know, in hospitals, there's so many people in hospitals that don't want to be in hospital, blocking the beds, and they need to get out when they can. And we need to have this streamlined so everybody's listening to everybody so we can move along. Thank you, Chair. I wonder if they could just talk about that, please.
Yeah, absolutely. So that home first approach is the approach that we always want to be taking for everybody, helping them have informed kind of choice around getting back to their usual bed. And that's always the first step and first consideration. I think how we listen to our staff, and you obviously had that feedback around where staff already know the solutions to some of the improvements that we need to be making as a whole system to get a better outcome for people. That's the work that we've been doing through the transformation programme we've started to hear about. So really getting those staff where they want to be, which is at the very start of a conversation with somebody. So when they're in the hospital, before we start looking about what their kind of discharge date is and what the option is for home, it's kind of what's going on for that person. Why not home? Let's think about home first. And then if there is any barriers to that, what can we do locally with community services to support that person out of hospital? And then only use those pathway bedded facilities when we really need to. And that's the shift that we're trying to continue to improve across a whole system approach to kind of help people do that, and focus on timely discharges and making sure those acute beds are free for those who absolutely need them, who are acutely unwell, but also making sure that we get good outcomes for those people who are then leaving hospital and being independent in their local communities.
That sounds very positive, Chair. So I hope you can keep it up, because it's important. and we should be bringing it up a few laps. Thank you.
Dr. Collins.
Yes, thanks, Chair. I didn't want to walk past an opportunity to thank both our voluntary sector and our community and the people who look after patients. So our carers, the families that live and care for people, who play such a vital part in timely discharge. And our health and care strategy and our commissioning intentions for next year, strengthening the role of neighbourhood teams and integration with our voluntary sector and our communities should help to make sure that people don't spend any more time in hospital than they need to. Some people are reluctant to leave hospital because they're afraid of what they're coming home to. And the more that we can work together to improve things in our communities to support families to look after their loved ones, then the more that we can do to expedite discharge. So thank you.
Thank you very much, Dr. Collins. And I think what I would like to say is that I'm really pleased that since our visit, it seems there's been quite fast progress in involving our social workers and social care assessors in the discharge process earlier. And I welcome the involvement to advocate for residents and help them make best decisions on their pathways. And certainly I would be really interested to go back in 6 months and talk to the staff again and see how their experiences have changed, and through this transformation process, what is happening. It's obviously absolutely key on the interface between health and adult care, and the more that we can work in an integrated way and involve our officers as early as possible, the better. So certainly one of the recommendations that I would like to make is that we go back and revisit that probably 6 months. And I've just got a question, if I may, and that is just, I'd like to know, so in terms of the no criteria to reside, which is on page 4, it's 18.2%, whereas Torbay and South Devon is 11.4%, so it's quite a lot lower. And I just wondered what the explanation is for that, and what target we're working towards, or is it too early to say? Thank you.
I'm going to leave my NHS colleagues to talk about the target, because I think that's in your domain. What I would say is that as part of the improvement work, I think we've had University Hospital Plymouth supporting it. And so as part of the MAID event, they came in and supported that, and they brought their learning. So a lot of what you're seeing in terms of what the strategy is, what are the things we learn, what are the things we need to change, they helped us identify it. So I think that's the difference, that some of the things that we're identifying that could be better are already working in a better way in their areas.
Thank you.
So no criteria to reside. Peter, correct me if I'm wrong. I think we're aiming for 8%. 8, does it sound? Yes, nodding. Yeah, and
yeah.
So I'd like to say, in Torbay, South Devon, in the smaller areas, as we're seeing a bit with North now, it's easier sometimes with geography to reorganise things to be more efficient. This end of Devon being as vast as it is a bit of a challenge, and the Exeter position is a bit of a challenge for us. That said, as you've reflected, we are accelerating at pace with a number of changes, and we're already seeing some improvements there. Going back to Councillor Julian's point about working with the patients and that sort of early involvement, what I would reflect is that actually the patients individually are very committed also to not being in hospital. So, and our colleague from the trust on screen at the moment would, I'm sure, agree that sort of any delay moving out that side is going to impact on people sleeping in day case units, ambulances being outside, people, you know, in corridors receiving their care, they're not being treated properly. And I think the position that we're seeing now is that everybody is into a creative mindset of, well, these are our commissioned arrangements, what else can we do? And we could do a little bit more and a little bit more, and really involving the patients within that. They know what they want, they know what little bit of extra care or extra resource from the voluntary sector or whoever might really help them. So we're kind of chipping away, and I think we we need to talk about management of risk. So yes, it does take time. Yes, we do need to make sure all of those assessments have been completed, but sometimes on balance, we have to consider the incoming people and managing the risk of incoming with somebody who's moving out the other side. But what I would reflect is the commitment we saw to getting that right, moving people out the other side is really there, and it's very, very important to sustain that, I think.
Thank you. And I think we've got Sam Higginson, the Chief Exec of RDU, has his hand up.
Yes, just to confirm that as health partners, we set off at the beginning of the year aiming for a plan of 8%, and we're some way off that. But as colleagues have already said in this meeting, we've got an opportunity now, working together through the MAID event and some of the other initiatives we've got underway, to really refresh our approach and get back on that trajectory, because it's really important in terms of ensuring that we can then admit patients into the hospital who urgently need care. So getting the balance right is critical.
Thank you, Sam. Donna Manson.
Yeah, I'm interested in that target. And hi, Sam, good to see you. And our colleagues, you know, we've had many discussions about this, but we see on page 4 quite a strong performance actually in the southwest, but with a target of over a 50% improvement. So we had the discussion this morning, and we see some really strong performance on, you know, proportion of new clients who receive short-term services. So I'm seeing some performance that shows positive, good practice. I suppose my question is really then when you go to page 14, which is a financial plan, about whether actually, question we were asking this morning is whether that financial plan isn't really aligned with the practice improvement plan. And I hear that we're all working together on it, but I suppose my simple question, is that a reasonable target? And will it actually take us into a space where the financial target compromises the care of residents in that pathway? Because we can all have targets, but I think if I was given targets by the members to improve things by 50% in 1 year, I'd be expecting I was dealing with a serious failure, and so that level of target improvement was required. And then I wouldn't expect such a target if actually within the southwest I was sitting mid-table. So target seems quite unreasonable to myself, and I recognise if you can't comment, but was that an NHS previous England target, or has that been a board target?
Sam, if you could comment, please, because when you look at that chart, it's 8% is like very low compared to where we are at the moment. So, and everywhere else. So is that a realistic target?
So Donna, that was the target that was agreed at the beginning of the financial year. My understanding was that that was agreed by all partners, but we should come back to that, because I think one of the bits of governance we need to really reinforce for next financial year is to be absolutely crystal clear at the beginning of the year the target we're all trying to hit and whether we've got the resources aligned to get there. I think that's a piece of learning for this year, isn't it?
I think, Sam, just to make it very clear to members, my point this morning about Devon being excluded from the governance processes is that, and I'm looking at you, because that was my understanding, is we were not part of that target setting, and in genuine collaboration and wanting to be part of the co-production and addressing this issue. It's a concern expressed by both myself and the leader that the new structure excludes us even further from that governance. All of local government in Devon offered to sit at the table with the NHS, whether it was to observe or whether to have voting rights. It does happen elsewhere in England, and we've been excluded from that process. So this is really a public pitch that we want to work together. We realise how hard it is, but if we're excluded from the governance, then it doesn't make it possible for us to stand in this room and to be held to account by our own governance processes.
Donna, absolutely. Obviously, as Chief Executive of the RDUH, that's not within my gift, but I fully recognise your point that if no criteria to reside in this group of patients is a collective endeavour, isn't it? So we need to find a piece of governance where everyone feels they've got a voice and we can all sign up to what we want to achieved together. For me, it's absolutely critical, but I can see Peter wants to come in.
I just wanted to echo Sam's point. I guess I hear what you say, Donna, and I will reflect that back. Clearly, it isn't my sole responsibility to sort out the governance for the ICB or indeed the new cluster, but I think it is really important that it is my responsibility to make sure that the right partners are in the room when we make really important discussions and targets. And particularly making the distinction between, I guess, improvements and transformation. We recognise that we will be coming on later on to the financial challenges that remain in Devon, and everybody will be very clear about. It requires, to me, large-scale transformation to get to best in practice rather than to be satisfied with mid-table.
I just think for clarification, it's important to note that we, as local government chief executives, have communicated to the new chair that we feel excluded from that governance, and the leader has directly stated that to the chair, and the position remains unresolved at this moment in time. But it's very important for members to see that we genuinely want to work together, and I've communicated on behalf of the leader here because he's not here today. We genuinely want to work and make this work together, but at this moment in time, the governance will not enable that to happen, and certainly not achieve that target that's set out today, would be my professional opinion.
Thank you, Tandra.
Yeah, so I absolutely support what the chief exec said. I think we need to be around the table. But what I was going to say is it would be really helpful when we get to the finance paper to explain what 8% unlocks, because I think if you're not inside the NHS and you don't understand how the sort of demand and capacity activity and the plans within there, why you need to keep occupied beds down to that level, what that capacity achieves in terms of the financial position. I think if the local authority was round the table, we wouldn't necessarily be signing up to an 8% target, because I agree it's a mountain to climb, isn't it? Even though we're getting positive green shoots, but we could then go in with our eyes open about what the implications are for us as an organisation, as well as yourself, when we're making those plans, because obviously it has implications for other services the NHS might want to fund.
Councillor Ketchen.
I don't know if the chief exec of the RD UT would be able to comment on comparing apples with apples. We've got a couple of different trusts in the southwest, have we not, where the demographics are somewhat different. I don't know if the chief exec would strongly say it's a favourable comparison for the RD or even North Devon to be compared with Plymouth, which I believe is a younger group of patients, possibly with more poverty, but often with less complex home care needs. And maybe that's why some of the NCTR outcomes are different, and maybe we should be a bit cautious about putting ourselves in the same pot with them for an 8% target. Any thoughts on that?
So I think you're absolutely right that the population is different in different parts of our patch, isn't it? So in East and North Devon, we have a proportionately older population. And although we have some pockets of very severe deprivation, on average, the level of deprivation is higher in Plymouth. So those dynamics mean that you shouldn't necessarily apply, I would argue, the same target across the patch. So we need to take an informed view. I think it's important to say the 8% we're talking about was a target for 25-26, and as a group of partners, we haven't yet agreed the level we need to try and hit for 26-27. So this is a really important conversation for us all to have in the next few weeks while we lock that down.
Thank you. I think what I would like to do, I think the issue of a target being set, which is, as a council, material and significant for us, which we haven't been involved in any discussions, is my understanding.
We do discuss, we are actually, and I have to say to colleagues in the room, we work closely together as colleagues, but it's actually at the, in some areas, but it's the governance of how our members represented and how are we as officers represented at that decision-making space. As Sam's quite rightly said, it goes into a process in the ICB, and that's where these processes are agreed or not. At the moment, Devon has, our Devon has no representation in that space, even though it's been pointed out that there are other parts of the country where we made a request for Plymouth, Torby and Devon to be in that space. And we have had a response that that's not possible, which seems, in my view, publicly unacceptable, considering we're the largest part of the system. So, and then I think, as I say, my colleagues in Plymouth and Torby feel we should all be working together on this anyway, because our families cross across the southwest. They don't all go to care homes or get care at home through providers with a line on the map. So they go across the different hospitals and they use different provisions. So that's how we want to work together on it.
So am I correct in understanding that we all work together, but in terms of the governance arrangements and the setting of the targets, as a local authority, we don't have a seat at the table? Is that correct?
So we're talking specifically about the Integrated Care Board. Every area is organised slightly differently, but it is meant to be in partnership with the local authority. So what Donna is referring to is the structure of the board and representation of the local authorities. And we are clustering, or the Royal We, our ICB colleagues are working through clustering with Cornwall at the moment. So I think it's become even more important that there's right representation around the table, and then that will help inform the strategic direction.
So it's not a decision for Dr. Collins or Sam Higginson, but I would suggest that as a committee, we raise that as a concern direct with the ICB by way of letter, because it's with the chief exec, because it's ultimately going to impact the health outcomes and the well-being.
It will be with the chair.
Chair.
Yeah.
There's currently no chief executive of the Devon ICB.
So it'll be with the chair, John Govett. He will have oversight. He's supporting the transition, the clustering, which eventually will be a merger of Devon and Cornwall. So that's where you should be raising the governance.
So if the committee's happy with that, we write to the chair of the new ICB raising concern about the fact that as a local authority, the governance arrangements do not allow us to be fully involved in the decision making.
It's more the point that actually I think in the spirit of collaboration and co-production, we genuinely feel we can help our NHS colleagues in this space by working together. And actually the pathway is such that it will only work if we're all there. But I think in terms of being represented and being part of the decision-making process, it's absolutely essential that that continues to be raised as a serious failing if we're not allowed to be at that table to work together on this. And it does compromise some of the work that we talked about this morning.
Thank you. Well, I would suggest that as a committee that I, on behalf of the committee, write to the chair of the ICB in the terms that the chief exec and our head of service has outlined. Would you be happy for me to do that?
Yeah, I second that.
Thank you. Jo.
Thank you. So just on that point, so the data within the graph there is showing the no criteria to reside position. So those are the people delayed. If we slightly reverse engineer that, what we're looking at with the improvement work and our next steps is not necessarily how many people are delayed, but what can we do to map the capacity and the demand to understand what we need to do. So collectively, we can't do that on our own as an ICB. We need our Devon County Council colleagues to support us with that. And as Peter raised earlier about the voluntary sector, etc. So what we're looking at for the mapping moving forwards is an understanding that the data is conflicting and it is different across different demographic areas and different hospitals, different services set up in different ways. So there is a bit of conflict on that. What we are absolutely committed to is to working with the trust, with the demand and capacity piece, to say, actually, if we assume then, say we've got 1,000 beds, and we assume that 100 people within those beds will have complex needs and need a complex discharge pathway of some description, our capacity mapping is around our ambition rather than who's going to be left behind and who's going to be delayed. So we're really looking at an ambitious process of saying, okay, if we've got 1,000 beds and there's 100 people that is going to need a complex discharge, what's our ambition? Our ambition would be that we get at least 75% of those people home and at least 20% on pathway 2 and et cetera, rather than at the moment where things tend to be weighted towards a bedded option, but really shifting the ambition back the other way. And it feels a lot more that we can work with a lot more confidence if we have an ambition rather than just focusing on the delays. And I would hope that that would offer some reassurance to the trust and to our DCC colleagues that actually that's where we want to go, A, because it's right for the people, but B, because actually the longer term impact then of some of those people who might have landed in a bed previously and stayed will have opportunity to be at home and have less dependent packages moving forward.
Thank you very much. Councillor Kitchen.
I'd like to keep a focus on what we think as a scrutiny committee is within our gift. It's not often we've got the clinical lead of the ICB and 2 chief execs almost in the same room, sort of by links, but good enough for me. And I'd like to hear from both chief execs and the ICB of what their views are in how their respective organisations can work better together, or what we can do as a scrutiny committee to put a spotlight on that and facilitate that.
Who would like to go first? Dr. Collins?
So I think I wouldn't want, notwithstanding what has been said on behalf of the committee and the leader about the high level decision making governance of the cluster ICB, I wouldn't want anybody in the committee to leave thinking, as I think Donna alluded to, that there isn't great collaborative work happening at every level in our organisation between local authority, apart from the board table. I think moving forward, to the councillor's point, our focus on developing really strong integrated neighbourhood teams, the shift that is pointed to in the 10-year plan around the shift from hospitals into community, from analogue to digital, and from disease prevention, all of those require us to work together to provide really strong community services and to rely less heavily on our very expensive hospital services. How we do that is really the focus of the big transformation plan that we need to do over the coming years. But that's how I see us continuing to work together, and that's where the committee should seek oversight to ensure that that is effective for delivering better health for the population through your work with the Health and Wellbeing Board, and particularly through the neighbourhood health plans, which will help us collectively agree and decide where our priorities are to deliver the best outcomes for our population.
Thank you, Sam.
Well, I would agree with everything Peter's just said. I think there's a really important focus we need to put on that neighbourhood piece of work. And I'm conscious at times what the NHS talks about as a neighbourhood is different from what local authorities talk about as a neighbourhood. So I think step one is actually for us all to agree the definition of the neighbourhoods in Devon, because that would actually take us forward. And then we need to accelerate that piece of work as partners. Within the context of the government's 10-year plan, it's really clear that hospitals are going to have to change, and they're going to become smaller, and their purpose will increasingly be around really looking after those acute episodes of care, whilst we need to support our population as far as possible to be looked after closer to home or even in their own home. So one of the things I would really welcome the support of this committee on going forward is your support as we embark on that change, because it will mean reconfiguring our services and changing how we currently deliver health services. And that's a really important agenda that we do together.
Thank you very much, Sam. I've got Councillor Tilsley.
Thank you very much, Chair. I just wanted to bring in our specialist advisor, Peter Hay, on this one, who's definitely more able to put a question before you. Peter, wouldn't mind bringing your concerns?
No, I think it's a very helpful debate. I think what is important, though, is that collaboration is at every level. And one of the issues in the CQC stuff is making sure that practice and top leadership are connected. So that is important that we pay attention to those sort of things. I think the other thing is, and I fully understand it, these are two systems under immense pressure. Both sides of it, if that makes sense. And I think it's just finding where is that space to elevate this, because actually this isn't just about discharge. This is about how you achieve better outcomes for people by avoiding unnecessary time in hospital at all stages of the journey and in all manner of ways. And I think there's something about just taking the time to reframe it about some really agreed outcomes for people, and then offsetting your system stuff underneath that, if that makes sense. Because I think somehow you've got to find some ways of taking the tension out of the system, because I think actually, particularly for the benefit of the NHS colleagues, this isn't going to get any easier. You know, the way local government funding is profiled for Devon is going to add challenges to the table in the next 12, 18 months. So I think there's just something about making sure that occasionally you can kind of just take that step to say what actually is the commonality here and how do we frame that. And that's really challenging when I know in particular for NHS colleagues, you've got enormous beasts breathing at you in relation to the sort of system pressure. But I just think that somehow that's got to be the space you find, if that makes sense. Because, and then I think it's that, what's the range of services that will make a dent into this? There is the balance between hospices, care at home, wards at home, all that kind of stuff. And how do you want to arrange your whole chips rather than necessarily putting it all on just discharge arrangements, if that makes sense. So I think it's just to encourage that sort of breathe out, kind of reframe it and see if we can find some commonality and then plan for what will be a very challenging couple of years.
Thank you, Peter. Thank you, Peter. I think I've had a couple of hands up. If we could just very quickly just go through any other points, because we've got the next item as well on the RDU finances. So if we could just move towards finishing this item. Councillor Ketchin.
My sort of reflection on what I've heard is that it strikes me is that we've heard about risk. Councillor Julian was talking about no risk. I think that's possibly a high risk strategy actually, but the rub is really where the organisations interface and how that can be improved, often at entry point rather than just at discharge as well. And that's, you know, I'd caution a no risk approach. I think it's about shared risk and how the organisations work towards that.
Thank you. Councillor Rogers.
Thank you, Chair. My question is there enough volunteers in the system to help this work? Because we're all talking about the need for volunteers. Are those volunteers in existence?
I think there's always a challenge around volunteers and how much you can expect across a whole system. And we've talked about the use of volunteers for the whole of the kind of improvement around in integrated neighbourhoods. I think in Devon we do have a good volunteer mobilisation, so we have really good connections with our local VCSE partners, and we do a lot of good work together. So there are a number of volunteers across our system. I think there's always a challenge about is there enough, and the key is about how we're targeting the activity that really matters to get the best outcomes for people, for those volunteers as well, and making sure they're comfortable with the work and the kind of requests that we're asking of volunteers and the support that wraps around them. So some of the volunteer grant funding and support that we provide is around that infrastructure to volunteers to kind of help make sure that we do keep them well as they kind of rely on that support from our voluntary and community partners too.
Thank you. So if we go to Councillor McGough, then Councillor Dawson, and then we'll come to our recommendations.
Chair, mine's really quick. Thank you very much to Pete Hay. You've raised a question I wanted to ask, so that's me.
Thank
No
you.
point repeating it.
Thanks so much.
Thank you. I just wanted to highlight something which is pre-hospital admission, really, that's going on at RDUH, which is the hospital at home scheme. And I think that should be mentioned in this, because in this whole piece of work, because you're giving people assessment and clinical oversight with them coming in and out of hospital for particular appointments and things, but all under an acute team, rather than actually becoming a patient an inpatient in the first place. I have someone in my family right now actually who's doing that. So we've really got to know that system quite well. Comes with its risks and challenges, but I think that should be part of this reflection as well, because that's bringing down hospital admissions. And when we look at the impact, particularly on people who are older or frail or have complex health needs, the impact just of being in hospital for 5 days or 10 days can be life limiting, you know, and cut someone's life short. So I think that ought to be part of this conversation when we revisit it as well, because it's kind of that prevention that we often talk about, particularly with public health. Thank you.
Thank you. Thank you, Councillor Dawson. Sam?
Well, just to fully support that comment, we've currently got 100 what we call virtual ward beds or hospital at home beds, which are fully operating, and there is scope to go further. To give the committee a sense of that, it costs me £17,000 a year to run a virtual ward bed versus £100,000 a year to run a community hospital bed. So when we're thinking about how we use our resources going forward, we absolutely need to think about how can we increase that use of virtual ward beds. We get amazing patient feedback about them. Patients love them. We obviously have to manage the clinical risk.
Thank you, Sam. Members' recommendations. So we've had a recommendation to write to the chair of the ICB. I'm suggesting that we revisit the issue of hospital discharges in maybe 6 months' time, that we have another visit for any members who are available to go back to the hospital, to the RDU, to the discharge team, and that we welcome all the hard work that's being done with our partners, with our NHS partners, to improve the hospital discharge position. But I wanted to see if there's anything else, whether you're content with those recommendations, or if you want to amend them or make any other suggestions.
I don't know if you'll accept this, Chair, but I'd quite like there to be, even if it's just a paper briefing from the NHS about the hospital at home scheme and what's happening, so we can see the full picture of what they're doing to kind of bring down those admissions.
Yeah, shall we have that when we come back in 6 months together with? Yeah. So if we can request a further report on the discharge position in 6 months, which includes a section on hospital at home. Is that okay? Should we go to a vote?
I'll second that, Chair.
Okay, thank you very much. If all members in favour? Thank you. Thank you very much, Sam and Joe and Peter. And so we're now going to move on to the next item, which is the NHS Devon financial pressure. So I don't know, is that Sam will be presenting the report?
I'm very happy, Chair, to talk about the RDUH position.
Thank you.
And then I'm sure Peter might be happy to say a few comments about the overall system position, if that's helpful.
Thank you.
To the committee as well.
Please.
So members of the committee will be aware, and you can see this in the report, and it's also available on the RDUH website in the public board papers, that on the 9th of January, the RDUH board met in public and agreed that we would have to amend our financial plan and forecast for this financial year. So at the beginning of the financial year, we had agreed with NHS England a break-even financial position, and on the 9th of January, we revised that to a forecast deficit of 44 million for the year. That means that we would then be in a similar position to both Torbay and South Devon and University Hospitals Plymouth, in that all 3 acute hospital trusts would be running significant deficits. So linking back to something that Peter said earlier on in this meeting, it has reinforced the need that we now need to think about how can we transform our services, because we need to bring the acute hospital sector onto a more sustainable financial footing, and that's the piece of work that we're embarking on at the moment. The key drivers of that deterioration in the financial position are really two areas. One, we've already talked about in this meeting. So the financial plan for the year assumed a level of, on average, no criteria to reside patients of 8% for the year. And the difference between that assumption and what we're currently running at, to link back to Chandra's question, is about £15 million of additional cost pressure. Alongside that, the Trust had assumed a number of saving schemes, particularly around workforce savings, that we have not been able to realise as quickly as we were hoping to be able to. And those two factors combined have contributed to the financial position. So we are now in a process of well underway in terms of planning for next financial year, along with other NHS colleagues in the system. And really the conversation now is about what else can we do to accelerate savings opportunities and look at options we've got to bring ourselves back into a more sustainable financial position. So, Chair, that's all I was going to say, but Peter, I don't know if there's anything you would like to add, and then I'm happy to take any questions.
Thanks, Sam. So as ever, Chair, I'd just like to inevitably make the distinction, A, that I am not financially trained, B, that I have to make the distinction between Devon ICB as an organisation and Devon's ICB's role in describing the system financial position. So as an organisation, we remain on track to deliver our financial plan at the end of this year. We recognise for the reasons that Sam has alluded to, that our providers have continued to work hard to deliver their financial plans, but some of their cost improvement programmes have slipped, and that has put extra pressure on it. We remain in dialogue with the region and national teams who understand our financial plan and have committed to deliver a new revised plan to the end of the year and into next year.
Thank you, Sam and Peter.
Can I just check for a point of clarification in terms of, it's always an interest of our members if we say we're going to do something and then it doesn't happen, but sometimes in that process, as we all know, things can change nationally that change that initial path. So for clarification, it's my understanding that when these initial plans were agreed last year, that there was going to be support for redundancy nationally by the government, and then that did not take place. So the significant plans that were in place could not be delivered. So the national goalpost shifted rather than thinking that just a local system did not deliver. So I think that's the first point. And secondly, I think that those early discussions about system deficit support that have always been in place for many years, again, that shifted mid-years, because I actually want to say in support of my colleagues and the decision makers at the ICB, and it's important to hear today, Peter, that actually the ICB's running costs, it would be helpful to get clarification, but it's my understanding that Devon's running costs actually fit in the government's envelope is within that scale. So actually the running costs of the ICB are very positive. I think it's going to be challenging because Cornwall's running costs might be more significant, but I would like those points of clarification because I don't want the members thinking that this is an underperforming system that set an unachievable plan. I think it was a very ambitious plan and highly challenged, but national goalposts did change that show some of the evidence in front of you today, but it'd be helpful to get that clarification so members understand that.
Thank you. Peter?
Thanks, and so Donna is correct. There were a number of assumptions made at this time last year for the 25-26 financial plan, and some of those goalposts did change. I think it would be unwise and unrealistic for us to say that that was the only reason that the financial positions have changed, but was undoubtedly a contribution. In terms of the running costs, I would need to provide clarification outside of this meeting about the exact figures. I think colleagues will know that we are currently undergoing a restructure to meet the new target financial envelope per capita for running costs of ICBs, and that will require significant reductions in our workforce, which we're working through at the moment. But Sam has something to add, I can tell.
Thanks, Peter. So Donna,
sorry, I think Tandra just wanted to come in.
I just wanted, I mean, Sam, you might be able to add it, so sorry to cut across you, but there was a unit cost that came out in the letter. I think members would find it really helpful for you to understand what the unit cost is that you're trying to work to, because it's quite significant in terms of the reduction.
Could you tell us what?
Well, let's. I'll try and pick those up, and Tandra, I might just have to ask you to clarify which number. But Donna, thank you for bringing out your first point. You're absolutely right. At the beginning, this time last year, when we were developing the plans, there was a lot of discussion in the NHS about access to national redundancy funding, and a large chunk of our plans was based on an assumption that we would be able to access that. And then subsequently, we were advised that that wasn't going to be the case for acute trusts. I think it is still the case for the ICB running cost changes, but obviously that had a major impact on our plans. As Peter says, we can't say that is the only reason why we've not achieved them, but it is a significant contributory factor. Tandra, apologies, I'm not quite sure which number you're pointing to.
So I've just Googled it. So I think what I'm talking about is the 30% real terms reduction, £18.76 per weighted head of population. So I just, I mean, those are just numbers to me, but
yeah, sorry.
It'd be helpful for councillors to explain what that means.
So this is, I'll bring Peter in, but this is the reduction. At the beginning of this year, the NHS was set a number of additional targets that we had to achieve. So we have to reduce our workforce, particularly our corporate workforce. We have to reduce our agency spend and our bank spend that's often used to support our work staffing levels. And we've got percentage reductions for each of those that we are performance managed against. And then finally, the number you're talking about is a 50% reduction in ICB running costs. But let me bring Peter in on that.
Yeah, as Sam has said, the £18.76 that Tandra refers to was set by the government as a financial envelope for all ICBs to calculate their running costs, which requires between a 30 and 50% reduction across systems in terms of those running costs. We are in the mid of a consultation to get us to a point where we have a structure that would allow us to focus on a more narrow scope of work, particularly around strategic commissioning, that would sit within that envelope.
Yeah.
So the point I'm just trying to make is that in terms of what lies behind this report, unlike our own organisation, where you heard earlier this morning that to transform needs investment to make it happen, that has not been in place for our system partners in the room. On top of that, they've got a 50% reduction target with 50% less staff strategically to lead that, and have nowhere near the stability that we have in Devon County Council from across the system, chief executive, directors, heads of service, team leaders. So that whole system change, double target, half the staff. That's what I'm trying to point out. I just find that absolutely unreasonable in terms of what people are being asked to do. And that's why I'm concerned that recognising where a system is and how to improvement is part of that improvement journey. And I'm really concerned for my colleagues in the NHS. I keep saying it, they're having to work in such a stressed environment, stressed system, without any of the resources to make those changes. And I think it's important that everybody understands that, and then the implications that might have on us as an organisation. And I say it with full support because actually Sam and Peter have been fantastic colleagues. It's important to say that to you today.
Thank you.
Thank you, Chair. I just want to build on what Chief Executive was saying. Is that 30 to 50% reduction attainable? Is it realistic?
I think if you're talking about the ICB restructure, the no answer isn't an option. So we will achieve the target through a restructure. The real question, I think, as Donna alluded to, and I'm really grateful for her words of support, is the people that are left within the organisation, will they be able to, through a narrower focus in strategic commissioning, achieve the transformation at the scale that is required to provide sustainable healthcare services for Devon? And that's an answer that is more difficult to answer.
Thank you. Sam?
Well, just to also say I'm very grateful for Donna's support as well. Just to fully endorse what Peter said, and I guess the implication for colleagues on the council is that we need to deliver a lot of this change agenda together, and particularly we need to strengthen what we call the place-based arrangements. So that's the place-based localities, and we've touched on the neighbourhoods as well. And realistically, the ICB is not going to have the resources to do that in the way that we might have originally envisaged. So we're going to have to work out as partners how we can work together to deliver some of that change in a different way. And we shouldn't underestimate that's going to be really challenging.
Thank you very much. Well, it paints a very gloomy picture and huge pressure for our partners in the NHS, and huge challenges. So and it's very difficult to see how these the financial reductions are going to do anything apart from have a detrimental impact on residents, because the reductions are so significant. So it's difficult to see, looking at, say, the RDUH budget position with the deficit, how that deficit can be brought down without very major changes. And I wondered if Sam could give us any insight into how that might happen and what impact that will have for people that rely on the RDUH for so many services.
Do you want me to have a go at that? So this is, we're right at the beginning of having to think about what that might mean. To try and put that in context, so I'm talking about a £44 million deficit at the end of this financial year for RDUH. That's on a turnover of about 1.1 billion. So that just gives you a sense of the scale of the proportions. But it will still mean us having to significantly think through how we can do things differently. Now, we're hopeful, as we touched on already in this meeting, that digital and technology may be part of the answer, and we can think about moving some of our services into that environment, as well as, and we've touched on this already, we need to think about how can we prevent more attendances at the hospital by working more effectively with primary care, the voluntary sector and yourselves in that prevention space. Because as I've said already, when we think about the implications of the 10-year plan and the funding settlement we've got, we are going to have to reduce the size of the acute sector over time. So it will mean us having to redesign services in a different way. And I'm acutely aware if we just get into a conversation with our local residents about taking things away, that's not going to work. We've got to get into a conversation about what is a positive neighbourhood-based future that people can buy into and feel safe with. And it strikes me conversations with this committee is going to be absolutely critical going forward, because we need to work together on this within the financial constraints that we're now facing.
Thank you. Committee. Councillor Rogers.
Thank you. Thank you for presenting the information. What does the headcount reduction look like in terms of number of people, and how is patient safety affected or not, hopefully, and what have you got to stop doing?
So for this financial year, we aren't reducing the headcount in the way that we had originally planned. So in effect, because we've ended up running a deficit and not reducing the headcount. And that's because it leads back to something Donna was saying. We were hopeful at the beginning of the year that we would have redundancy funding in order to make that change, and we haven't been able to access that. Going forward, we've been challenged, as all NHS organisations, to reduce our headcount, and in particular in non-patient facing services, as well as I said, our bank and agency spend. So we will have to start there, and over the next few weeks model that implication. So I'm very happy to come back to a future committee and talk you through the specific numbers, but I can't give you a specific number at this point. We absolutely start from a place where we need to make service changes with the safety of patients paramount. That's not to say that services won't look different in the future, and we've already had conversations in this meeting about managing risk in a different way. But that's the key point. We've got to redesign our services in a way that is safe for our population.
Thank you, Sam. I've just seen Tandra.
It's just a clarification. It's an acronym. I don't understand it. What does DBV stand for? There's a chart.
Sorry, we're terrible in the NHS, aren't we? But you should probably, in your language, it would be savings.
Oh, okay.
It's delivering, we call it delivering best value, and we use that as a way of trying to engage our clinicians in the conversation.
Donna might steal that as an idea.
Thank you, Sam. And I think there was quite a lot of abbreviations and things like FOT, which I know is for future outcast. No, something outturn.
Forecast outturn.
So yeah, so I don't know if next time, thank you for the report, but maybe next time we could have I don't know if it's possible to have a few fewer of those. They're quite alien to, certainly to me anyway. But Peter, did you want to say anything?
I was just responding to the councillor's question around numbers, I guess from an ICB point of view, where we've alluded to our current reconfiguration to reduce our running costs by 30%. We're in the middle of a consultation with our staff at the moment, which is clearly very difficult for all concerned in the ICB, as we've already talked about. So the exact numbers won't be apparent yet, but like Sam, we would be happy to describe that further on when it's appropriate.
Thank you very much. Did Councillor Julian have his hand up? Thank you.
Thank you, Chair. Before I start and ask my question, I mean, if we could sort these acronyms out, because I'm useless at acronyms. If we had it in proper layman's terms, I'd understand it, because, you know, we're all looking, oh yeah, we know, but nobody knows. So if you could sort that out, it'd be fantastic. But anyway, my question is that, you know, you're saying trying to save money and we're moving into technology, which you understand, you know, we're all going to get technology, but patience, we all need, you know, we are humans and we all need to talk to one another, and you know, and if we lose sight of talking to one another, you know, it's frustrating, especially if you've got some complex needs or something. I'll revert to whatever, you know, technology they're sorted out, but we do need to be together. We do need to be able to talk to one another, and I feel that yes, you've got to save money, got to have technology, but you don't want to lose the one-to-one with patients, basically. So what are you going to do about that? Thank you.
Well, firstly, Councillor, let me assure you, I will try and fix the acronyms for next time, so I apologise regarding that. In terms of your technology point, let me give you a couple of examples. So I imagine most of you in the room have a smartphone. I imagine the majority of you now do your banking on your phone or over the internet. I imagine last time you went on a holiday, you probably booked it on the internet. We currently do none of those things in the NHS. You still have to phone up the secretary to get your hospital appointment. You still can't book your hospital appointment through the internet. And so that's one of the technological journeys we need to go on. Similarly, something we've just introduced in the last few months at the RDUH, we've introduced something called ambient voice technology. So that's in outpatients. And what that means is, in layman's terms, is basically the consultants have a microphone and they're recording the patient conversation rather than them being hunched over the desk, typing up the notes. And actually, we've now seen over 1,000 patients in this way, and we've had fantastic feedback because the patients can look the doctor in the eye rather than the doctor being distracted. So we've got to find ways of harnessing technology to ensure that we can become more cost effective and efficient.
Thank you very much indeed. And I think we're about to close this item. So I don't know.
I think I just finally would like to point out the scale of what we're facing here, because I do think there is a bit about additionality or exceptionality for Devon, or that trajectory of change. So I've just been checking with Lisa here on the scale that what Sam and his team have been facing, but you know, it's 69.6 million in a 1.1 billion budget, Sam, and then a gap of 40, that would be like us facing about 120 million pounds, 120 million pounds in our budget in 1 year. That's the scale of what Sam and his team are facing. And I suppose, Sam, the other bit concerning for that, having received nothing nationally, because I know you worked a different funding system, but that would be asking us to make 120 million pounds worth of savings with no transformation funding, no flexible use of capital receipts, and no ability to reduce staffing costs. So again, gives you the scale of what you're looking at when a high proportion of your budget is actually staffing to deliver services. And then, Sam, I suppose my final point for clarification, because not only that being hard enough, I noticed that only 26% of your plan is recurring. It's my understanding, Lisa, that normally we hit about 80% recurring as a council. So we had 21.7 million to make this year, not 120. And then you can imagine if you only make roughly a quarter of your savings, what that means for the next year, So I just think it's important that I'm happy to send it, Chair, to do a bit of comparative analysis, but you can't underestimate the scale of what our local hospital has been asked to do here in Exeter. I've never seen such an ask, and it's my understanding, Sam, that in that context of where you are, that next year is going to be even more challenging. And that's why I said this morning that I actually felt that what's been asked of our local NHS partners is unreasonable, and that there is a need for some form of additionality. And I say that because actually we've got a huge improvement journey. We've just heard about in adult social care today, and we're all absolutely want to do what Sam's just described, keep people at home for longer. But, you know, I've not even started on the fact that if you begin to look at our children's improvement journey and our SEND improvement journey, which is all within those pathways into the hospital and all the assessments we do, I just think it is an unreasonable challenge that our local NHS partners are facing. And I would hope that if we were in a similar circumstance, Sam, that you would express the same. But I'm happy to provide that comparative analysis to show you the scale of what they're facing.
Thank you, Donna. I think it really does bring it home that our NHS partners are being asked to do well, it seems to me the impossible. And it's totally unreasonable, and the pressure that it puts on the people working in the system, yeah, it's quite unbelievable. So anything that we can do as your partners in that respect, please come back to us. And I see Sam's got his hand up.
Well, just to say, I'm really grateful for Donna's support, and we're going to need the support of all partners to face into this challenge. So, and as Donna has said, we don't have the same flexibilities that local authorities often do in terms of potentially different ways to manage things. So I'm really grateful for your support, and look forward to the conversations ahead as we try and remodel services, do our best for the patients of Devon.
Thank you, Sam. So I'm going to close this item, I think, and say please come back to us, please keep us informed. And I think we'll also look forward to seeing from Donna the comparative challenges, the financial challenges faced.
Just a quick synopsis, but we'll get the exact details, but it is of that scale.
If I could just record our thanks to Sam and Peter for coming and speaking to us today, and clarifying and giving us a full understanding of actually what's happening. Thank you very much. Oh, moving on to the next agenda item, which is the Torbay and Devon's Safeguarding Adults Partnership Board Annual Report. And I'd like to welcome the Chair of the Partnership Board, Paul Northcott. Paul, would you like to present your report?
Thank you very much, Chair. So good afternoon, everybody. As just been said, I'm Paul Northcott. I'm the Independent Chair for the Torbay and Devon Safeguarding Adults Partnership Board, and I'm here today to present the annual report to you. I don't propose to take you through it in any great detail. It's been circulated to you previously, but just to give you a bit of an overview and a bit of oversight, really, about the work of the board and the report itself. Excuse me. To put it into context, the board under the Care Act's got 3 responsibilities. So one responsibility is to actually produce the annual report, and obviously to present it to forums like this. We've also got a responsibility to produce an action plan, and you'll see within section 9 we have a variety or 3 priorities, and the action plan, just to provide assurance, there's a detailed action plan that sits beneath the whole of all of the activities that are conducted by the board itself. And then the third responsibility under the Care Act is that we should have a robust system in place to deliver safeguarding adult reviews. And again, I'll talk to you about that very briefly in a moment. The report itself is pretty self-explanatory, and it provides an overview around the coordinated activity that occurs across Devon, across all the partnership agencies within Devon, and obviously adult social care are one of those agencies, and obviously who are here today to provide that assurance around not only the board but also around how adult social care play a vital part within the statutory agency process. The report itself is set out in a number of different sections. You'll see within section 5, so the first part of the report is pretty self-explanatory, but if I just mention section 4, it details the partners and the agencies that work together with the board. And just can I provide assurance to all the councillors that we get really good attendance across by all the strategic partners to the board, and we do monitor attendance as well, but we get really good strong support for this particular board. Section 5 details very much around the safeguarding activity. It provides a bit of a simplified data overset, really, and it's just a snapshot in time, but we provide that to give you some idea of the type of data that we look at as part of the board process. We've got a performance quality assurance group that reviews the data on behalf of the board, and I get regular updates around that data. And obviously, you'll see within the structure of the board that we've also got an operational delivery group which monitors the data as well. But I do, outside of the process, I do get regular updates from somebody like my colleague Helena Riggs, who's a principal social worker, from a safeguarding perspective, and acts as the bridge really between the board, the partnership, and actually operational activity as well. You'll see within probably the most important section for you to look at is section 6, the Safeguarding Adult Review section. We have got a really robust Safeguarding Adult Review quality assurance process in place as part of the board. So the Safeguarding Adult Reviews, and you'll see there, we've got a number of recurring themes within those adult reviews, and the actual report details some of the reviews that have actually taken place in the last 12 months, and some of those reviews, the outcomes, the outputs from those reviews in terms of learning, in terms of recommendations. And again, I've talked to you earlier around that quality assurance process that we've got in place. So we regularly monitor the recommendations and the actions that come out of these types of reviews to ensure they're actually put down into operational practice. Now, some of the key themes coming out from those reviews are self-neglect, and that's a national issue, national problem. It will be reoccurring, but there's obviously work that can be done, and we have done as a partnership, and that's detailed within the report as well, together with neglect and acts of omission. And those are two of our prominent issues and risk issues for us within Devon. But there's also mental health, substance misuse there, and again, those are the types of things that we do see coming from our Safeguarding Adult Reviews, and those are the types of themes that we concentrate on as part of the board process as well. Section 7 is very much around those subgroups, and I don't propose to take you through all of the subgroups, but we have got a community engagement group. That community engagement group we utilise really to bring sort of the system alive, the processes that we're talking about as part of the board alive. So we get an update at every board. We have a person with lived experience, whether that be a frontline operational worker or an individual with lived experience. And that community reference group, engagement group, what they provide to us is they provide the ability to co-produce work. So they've assisted us in posters and other documentation. They've taken on Awareness Week as well, and they assist us together with that. Section 8 are key partnership achievements. That documents how all the agencies have worked together over the last 12 months, together with the board. And I've got to say that we often look at the negatives and identify some of those areas of learning, but we've got some great work. We've seen that through some of our frontline activities. Sometimes we don't recognise that, and certainly we've had some really good demonstrations of that at the board, presentations at the board, particularly around the work that's been undertaken by adult social care and mental health and the rest of our health colleagues as well. So that's the report as it sits before you at this moment in time, and I'm open to any questions, Chair.
Thank you very much, Paul. And I'd also like to thank you for the training that you've helped deliver to our members and are helping to deliver in the coming weeks. So thank you for that. Members, over to you for questions to Paul. So I'll start with a question. How does the board assess its own effectiveness?
Okay, at a number of different levels really. So I'm part of the process, both regional chairs, national chairs. So I'm looking at top level best practice and regional best practice and bringing that back into the board in terms of assessing and making sure that we're looking at the right themes, we're looking at the right risks. And that's included me attending one of the other boards as well to the quality assurance process, or the process within Devon and Torbay against the process that we actually run. We do complete on an annual basis an audit process, which goes nationally, so that's requested nationally. So again, it benchmarks us against some of those national audit processes. And in the past as well, we've also conducted a self-audit from our partners. So we put out questionnaires to our partners around the board itself and the work that the board actually undertakes. But we also do a lot of audit work within the board.
Thank you very much. Members? Councillor Rogers.
What keeps you awake at night at the moment in terms of your role within this position?
I mean, there are specific risks. We've heard one of them today around the impact of changes within health, and so if you look at it from a strategic perspective, that's probably one of the most significant areas of risk for us. It's on our risk register, and that's because from a safeguarding perspective, we don't know, and we don't know what that's going to look like from a safeguarding perspective. That's been looked at nationally at this moment in time through the national chairs, and there's ongoing negotiations and discussions with the government around that, what it looks like in this space. but as you've heard today, and I've been sat in the back listening to that, it's a bit of an unknown territory for us at this moment in time. In terms of other risks, again, it's just around, we're going to get some of these reoccurring risks around self-neglect, mental health, drugs, alcohol, and it's around that coordinated approach and working together with all the other agencies to ensure we can deliver the best possible services, that coordinated service delivery to frontline practice and actually see the change. And I think those are the types of things that certainly are top of my list.
Thank you, members. Councillor Dawson.
Thank you very much. There's an awful lot to take in, isn't there? I'm just looking at section 9 with your 3 points about your 3 strategic priorities for the period 25 to 27. How confident are you that they're realistic and achievable? And when you talk about improving awareness, engagement and inclusion, do you benchmark that? Is there any way of sort of seeing how much improvement are you looking to make? Thank you.
Thank you. So annually we review our priorities. So these are sort of 3-year priorities, but annually we review our priorities. We're just about to go into the next quarter and again get all our agencies in the room to ensure that the priorities that we're actually delivering here are the correct priorities, and just to ensure that we're pretty agile about the way that we're actually delivering the board's priorities itself, and that does include our colleagues within Torbay as well. Yes, so in that respect we've done a lot of work already around these priorities. They were benchmarked in terms of our business plan, but I've got to say there is no specific national data set for the boards. So we look at best practice nationally. We look at benchmarking perhaps around some of those key areas which I've identified within that within the data sets, and certainly around engagement. The qualitative side of that, we rely on our community engagement group really. So again, we get a feel for that at every board around frontline practice. We have professionals deliver to us, and actually the engagement piece as well, very much around that community engagement and reference group as well. They provide us with that detail around what it's like to experience the services. We also have engagement from other organisations like Healthwatch, and they give us a good sort of litmus test as to where we are and where services are with regards to the delivery of those services. So those are the types of things that we look at.
Thank you. So one of the key things I guess a lot of work happens kind of below the actual board level. But I guess one of the key things is to make sure that you've got the right people going to your board from all your partner organisations, and certainly like in at least one other committee board report from another safeguarding board, I've seen that they've kind of shown where the representatives go to all the meetings, and I'm wondering if that's I may have missed it, but I wonder if that's something that would be helpful to include for this particular safeguarding board, because if you don't have the right people in the attending your board, then it can be much more difficult to achieve your outcomes.
It's not shown within this particular annual report. It's just in terms of this report could be extremely long in terms of the process. But what we do is we monitor that on a regular basis, both at the board, but also outside of the board process. So I know who's attending the subgroups that sit beneath the board, who's attending our operational delivery group, which is a real engine room that delivers a lot of this operational practice. And where there might be a lack of engagement, what we've done is I meet with a lot of the strategic leads anyway outside of the process. So I'll discuss that together with them to make sure we've got the right individuals that can make the right decisions at both the board level, but also at the subgroup level. So those discussions do take place. So we do monitor that. We have changed the structure of the board as well. And again, we've listened to the board members and the subgroup members as well. And in order to make sure that we're pretty slick in the way that we actually deliver our services, what we were doing is we had 2 previous subgroups. And what we're doing is we were duplicating a lot of work, same individuals going there to those groups. We know time's precious because of the issues that all the agencies are facing. So we've listened to that, and we believe that we can deliver the work more effectively through the amalgamation of 2 of those groups. So we're monitoring that as well. But we do, just to re-emphasise it, we do get good attendance, really good attendance.
Thank you very much, Paul. Tanja?
Yeah, so I just wanted to speak in support. So it is a strategic level board. He does get senior attendance. I think there really is good attendance. So if there was something that came up that I couldn't, I would always make sure that meeting was covered. And I can speak from personal experience. Part of the role of Paul's role is to hold us to account. And also there is active debate amongst the partners. So if we've got concerns, so just playing to your the point that you made earlier, that the priorities is something all of us deliver. So it's not just Paul and the team delivering on those safeguarding priorities. It's a partnership delivery, and we worked together to make sure that we deliver on it.
Thank you. Members, any other questions? I've just got one more question, if I may. And that's around embedding learning from the SARS. Do you have like a clear audit trail of what each specific learning is, who takes ownership of that learning, and then going forward, how you make sure that it's embedded forevermore?
So part of the quality assurance process, when one of these adult reviews are actually written, the learning will be clearly documented within that specific report. Underneath that will be sitting the recommendations and then the action plans. What happens is then we monitor the action plans really on a weekly basis, it's fair to say. So we monitor the action plans centrally on a weekly basis. A lot of those actions, they're already identified, they've got specific owners, so it won't be the board itself that got ownership, picking up what Tan's just been saying. It's those specific agencies. They report back to us on a regular basis. Where we have got any concerns around the delivery of operational practice, then I go and meet together with those agencies as well, and we can discuss those and we can progress. Then outside of that, what happens is we feed back in. We've got master sheets, and all the information is fed back in around the sort of the changes that have been implemented. That's then reviewed again, both at a subgroup level and at a board level. And then finally, then the whole process comes back to board and will only be actually signed off once everyone's received that assurance that those actions have been completed.
Thank you.
Can I just add to that from an adult social care perspective as well? Once actions are assigned to us, we have our own internal governance. So we have an internal safeguarding governance group where those actions are assigned owners. So there's a clear delegated responsibility. The completion of those actions are fed back to the governance group, who confirm their appropriateness, that it can be recommended to the board for closure. So we've got that own internal governance piece within adult social care as well.
Thank you very much indeed. Thank you, Paul. I'd like to thank you I don't think we've got any more questions or comments. I'd like to thank you very much for coming today and presenting your report and for all your hard work. Thank you. Next item on the agenda is progress update on Newton Transformation Partnership. Sandra.
So I will just say a few words, and then my colleagues may want to come in because they've done a huge amount of work. So I suppose the first thing to say, this is a moment in time. So this was written at Christmas and we've come along much further. So what we've been focused on in the first part of the work with Newton is in that diagnostic. And they've now concluded, I think they had one more area they needed to look at. So that's sense checking, the scale of the opportunity and what we would need to do to achieve that. And they've the work that they've done is with us and partners, but with frontline staff, getting them on board to look at cases. I explained that in the previous meeting, didn't I? So to understand if they got the best outcome, what difference would that make? So what we've got is a much clearer understanding of the areas and what we need to do to deliver on them. As we move into March, that's when we'll be fully mobilising. But at this stage, what we've been doing is, agreeing how we were going to describe the programme, and that was something that our staff voted on. So that's where Living Well in Devon came from, and making those connections with partners to make sure that they're involved. We had an event last week with our extended leadership team to work out who are going to be the various leads for the programmes of work. and just to understand what was involved in that. So an awful lot has happened. We have taken a highlight report to the Strategic Change and Improvement Board, which has got quite a lot of detail in there. And I think there's going to be a standing overview group, isn't there, for scrutiny. So lots going on, but it's not really captured in this paper just because of the timing. So I think we probably need to consider how do we make sure that you get a more contemporary update when we next meet, and how we update you outside of the scrutiny meetings themselves.
Thank you very much, Tanja. I don't know whether Councillor Keeling's put his hand up.
Thank you very much, Chair. Just to add to what the director said there, I met with the team just before Christmas, the base team. I was very impressed with their enthusiasm and youth. Can I say that? Oh yeah, all our team is younger than me. Anyway, just to set out our key principles within this was co-production with staff and partners to ensure ownership and a sustained long-term impact, evidence-based discussions using data and diagnostics, skills transfer, so improvements are sustained beyond the partnership. But what was really important, and I felt I really wanted to mention this, was the principle of focusing on better outcomes for residents, not just the financial targets.
Thank you very much, Councillor Keeling. And I want to say that we've got a visit lined up, so members are invited. Thank you very much to Amy for organising the visit on Thursday to Somerset. Any members that haven't signed up to it, I don't know whether Councillor Barry, as a new member, has received an invitation. So we're going to Somerset Council to talk to Newton and council officers, because Newton are already working in Somerset. So I'm really looking forward to that visit. I think Councillor Keeling may be attending as well.
Absolutely. I do have a doctor's appointment, but I'm not dying just yet. So I'm more than happy. More than happy to come along to that. I'll cancel that.
And I think after that, then it'll be a really good time to look at the terms of reference of the standing overview group, because we're going to be convening. I don't think there needs to be any kind of set membership of it, but the committee members will be invited to attend on a regular basis to monitor the progress of Newton, because it's obviously so important for transformation.
So what we can do for that first meeting is walk you through the programme, because an awful lot has happened. And I think because we are talking about it all the time, it's quite tricky working out what you don't know yet. And probably quite a lot, actually, given the fact that you're not living and breathing it. So we can certainly do that alongside Newton colleagues, maybe start off with a background context presentation, and we're going to talk you through the work streams, but also the KPIs that we're going to use.
Yes, I think that's because there's the data from that's gone to the performance board, so I think it'd be helpful to see what the data looks like from the outset. So yeah, that would be really good. Members, comments, questions, concerns? Councillor Rogers.
We've the NHS and Newton work with the NHS in some areas of the country. Obviously, in the correspondence that we're going to do to government, can we reference that they should think about how they use Newton in Devon to help Devon? NHS.
So is that the government, or is that the? So we're already talking to the NHS, and so they will benefit from the work that we're doing with Newton. And so the council is fully funding that, and obviously Newton will be very open to conversations if they want to work with them to help with their transformation. I think it is quite large scale what they're going to have to do, and I think they probably need to think about the time. And Newton will absolutely support with professional opinion and data for the NHS and us to perhaps make representations to government. I think that's what we were talking about in the earlier budget meeting.
Yes. Thank you. Questions? No?
I'd love to have a comment question, but I'm just excited to see what happens next. So I'm waiting with bated breath.
Thank you very much. Any other, should we move on? Okay, thank you. So I think the next item is the Health and Adult Care General Update. So this is an opportunity for members to ask any questions. I think we're quite unusual in having this joint update across adult social care and the NHS. So I was really pleased to see in it information about the compliments and complaints, because that's new. So thank you for including that. And interested to see that a number of the complaints were about the financial services aspect rather than adult social care. And I don't know whether, I mean, I know they're just small number of complaints.
So overall, we get a very small number of complaints. And actually, we actively encourage people because we want them to feel like they can feedback about services. So you're talking about a number which is of a not a particularly big number, and there is a significant improvement journey. And I would say that things that will make you more likely to complain, I think finances are just one of those things that are going to make people more likely to complain than other aspects. But it's an improvement journey, and we expect that overall proportion to reduce as those improvements continue to kick in. So they've made significant inroads into working with people, getting those assessments done more quickly, etc. And I think as we go through that, you'll see a much smaller number. Oh, but we have got Helen Wyatt on.
Thank you very much, Tanja. Helen, did you want to come in?
Hello, apologies, I joined you ever so slightly late for that discussion.
Oh,
So was there a specific question you'd like me to answer?
No, I mean, I know that the number of complaints is in terms of like the percentage of overall things that we do is very small. But it's just about the financial services. So that's not actually our adult social care, is it? And I just wondered if you've got any comment on that.
Not directly, no, it's not. But obviously we try and keep a holistic picture of the complaints that are related. There are, in brief, there's conversations ongoing with managers within that service about understanding why there's an increase in complaints and how they can tackle them better. So that's an ongoing piece of work at the moment.
Thank you, Helen. Donna?
Yeah, I'm happy to pick up this on behalf of the Director of Finances, but also because I've been involved in it. So this is a very difficult task for staff to do. You know, in terms of recouping finances linked to, often linked to families that have lost someone and that process. So we met with staff to consider what kind of, how difficult that task was. And I think important to say that we didn't have that right, and the number of people in that team, the amount of support in that team. So we have a thing called sprint methodology, which is we take a very, as it says, a sprint at something over a period of time and try to get a really, you know, flood it with additional staff and real focus and check in and try and get an understanding of where to improve elements so that staff can do that job faster and with support. And it will come through as part of the budget reports coming through month 9, month 10, because I've already seen the draft of it, that actually firstly that the staff are doing a much better job in the outcomes and the recouping of that money from families, but equally so we need to reflect on actually how many staff we need in that role and then how we support them. So we've learned a lot through that process. We can evidence a much better outcome, but I think the learning point is absolutely in the amount of support that some of these teams need, because every phone call is a difficult one and very challenging. And also when huge amounts of empathy are needed or families are still very distressed. We still got to carry out that task of that debt recovery. It's our job. So I think it's probably one that would be good looking at Lisa to, once we see the good outcomes that have come through, it'd be quite a good one for us the committee to consider looking at, because it's very much one of those ones between the different directorates and how well they work together. But I wouldn't underestimate the impact that doing that all day long has on the staff that are asked to do that job. So just like in Helen's team, although you do get compliments, Helen, most people phone up to because they're upset or they're anxious. And it's, again, another team in the council where we need to think about how we support well-being and the tasks that they're doing. But certainly the outcome has significantly improved. But again, additional training and support is an ongoing learning point for us. And we did bring in a new team of people to supplement that, because I remember meeting them in the building. So we need to review what the next steps should be for 2026. And I would suggest that there's further work to be carried out, both in terms of the number of people we have working in this area, the way they support each other through this task, and also the amount of training that we need to make sure that staff have in this area. It's one of those unsung groups of staff who do a very difficult job every day, and my reflection is that I should have had more line of sight on that earlier. So I just want to say that for any staff listening.
Thank you. And Helen may have missed, but I said that I was grateful for including a section on compliments and complaints in this general update. I think it's the first time we've had it, so thank you. Is there anything that you would like to say about the compliments and complaints section, Helen?
I don't think there's anything specific to add at the moment. I've got some analysis work to undertake, but that will be brought to you. Apologies, I forget the date, but next time I'm due to come and give you a more detailed update, so I'll be able to drill down into much more detail at that point for you about the first 2 quarters of the year.
Thank you, Helen. Any questions on the composite report from members? Councillor Julian.
Yes, it's just that when people phone up about, to get complaints, it's either the press 1, press 2, or just hanging about, which winds people up. And this is what happens. And I think they shouldn't get take it out on the staff, but that's where the initial thing comes from. Or they are asking for somebody because they're frustrated or whatever, and then they're speaking to the wrong person rather than say, can you put me onto the right person so they can be listened to. And I feel that some of these complaints could be avoided if you were put to the right person straight away so they can listen to them. And also the face of when they make the phone call, that get answered a little bit. But I mean, it's everywhere. Don't get me wrong, it's just not just for the NHS, but it's everywhere. And it wants to be a bit more efficient. It used to be years ago, and we seem to have lost the plot because technology seems to be the best way, and then you wind everybody up. So I wondered if we could improve on that. If you can let me know, that'd be fantastic.
Helen, would you like to say? Or...
Sorry, I didn't realise that was a question directed to myself. So my team, while we do take calls from members of the public to raise complaints, they aren't specifically for adult social care, they are for all services. We do have a limited team answering those calls, unfortunately, and the number of complaints that we're dealing with is high, and so it does mean we have to have a very careful balance of where we put people's capacity in terms of processing new complaints versus answering the phone, because we want people to do a good job when they talk to customers. We want to make sure that we've heard their concerns properly, and as you point out, Councillor Julian, we want to make sure, if we can, we're getting them through to the right people, but primarily our role is to take the complaint and then process it through. So we will, as part of that process, look to see if there's any opportunities for early resolution, and that will be part of a conversation with the relevant managers in whichever service it might be about. But I don't think we can commit at the moment to improving our phone response times, but we don't have the technology to measure that within my team currently anyway.
Thank you, Helen.
Thank you.
Councillor Rogers?
Thank you, Chair. I just want to say thank you on behalf of residents who are digitally excluded, because I'm constantly giving your number and they're very complimentary about the service they receive from your team. So thank you. Your team worked really hard, so thank you for that.
Thank you, Councillor Rogers.
Thank you.
Any other questions or comments? No? I've just got one very quick question. Do we have a date for the CQC? No. When we're going to get the inspection result? No.
It's indicated by how long they take.
Okay. Right. Scrutiny work programme. Thank you, Helen. Scrutiny work programme. So I don't propose that we have a long debate about this now, but maybe if anybody's got any comments on the work programme, drop me an email, give me a call. Thank you, Fred. Councillor Dawson, item number 13, champion against domestic and sexual violence and abuse.
Thank you. I'm not yet a champion. We are all meeting as a group, and that's been put off a couple of times just to really understand our remit and where we can go. But I'm making a list of places that I'd like to engage with, like GP surgeries and places that may not be utilising free training and stuff like that to be able to respond better to disclosure of information and things like that. So yeah, we've got plans and things, but we're just not as busy as we want to be yet, because we want to all meet together and sort of understand that remit first. Thank you.
Thank you very much, Councillor Dawson. And then item 14 is information previously circulated. And I'd just like to draw members' attention to the letter that we had from the South Western Ambulance Service, who we asked to come to the chief exec, who we asked to come to our committee twice in 2025, and I was really pleased to see that they will not be withdrawing from any Devon Fire co-responding stations until they're assured they have an equal or better alternative in place. So that's a significant difference from their opening position. So I'd like to thank all the members who participated in those meetings and who raised questions with Dr. Martin. I think that it made a material difference to that position. I think we were quite right to express our concern in the way that we did. And I'm pleased also to see that the ambulance service is going to be consulting with the Chief Fire Officer to explore ways to enhance any future schemes, specifically increasing availability, response time, skill set alongside revised governance. So I think we just we need to be kept informed. We need to ensure that we're updated. I propose that we go back and ask for an update. And also we've been invited to visit the 999 Emergency Operations Centre in Exeter, and I propose that we organise a visit for those members that are interested, and that we also ensure we liaise closely to ensure that those kind of contractual arrangements between the fire service and the ambulance trust are maintained, and if there's going to be any change, then we're kept fully informed in advance of any proposed changes. So I think it's positive news. It's much better than it originally appeared to be. I think it was in July last year. So thank you for the committee for everything that you did on that, and we'll keep that as a watching brief, I think, going forward.
I'd like to second that, Chair, because I think that's brilliant. We need to keep on top of the game here, because we don't want anything slipping through the net secretively. We want to be informed, like you say.
Thank you. Thank you. So I don't know whether anybody has any other comments.
I think often in this room you thank us for the work that we do, but I was absolutely delighted when that letter came through, and I was really proud of you as a committee, because we had residents in this room really concerned about the impact it was going to have on people's lives. So sometimes it's important to say to yourselves, that's a first-class job to have something changed, you know, externally, and it just to say to you, it does really make a difference. And I think it's important that that's communicated back to the residents who did come and stand and speak for their communities. I don't know if we know who they were, but if we can go back to them direct and communicate, because I know some of them had come from a long way to stand here in the committee and speak to you. So I think it's important that they hear that their words had an impact on you and then an impact on the service.
Thank you very much. Yes, we'll certainly make sure that that happens. Thank you. So I think that's the end of the agenda. So unless anybody has anything else to say, I propose we close this meeting. Councillor Rogers.
I just wanted to wish our chief executive a good health and well-being rest of your day, because you've been very brave, stood up there, and you deserve our applaud for spending the whole day on your feet. I hope someone's looking after you.
Thank you. I totally agree. Thank you, Councillor Rogers. Thank you, Chief Executive. Thank you. Thank you very much, members.